This next talk is on the respiratory treatment progression. By the end of this talk, I think you should be able to empirically treat patients in respiratory distress with escalating treatments that include passive oxygenation and positive pressure ventilation. You should also be able to explain the indications and contraindications for non-invasive positive pressure ventilation. In our last talk, we discussed the respiratory assessment triangle, which looked at oxygenation by assessing their SpO2 and applying some supplemental oxygen. We looked at ventilation using a blood gas and your stethoscope, considering their respiratory rate and their tidal volumes. And we looked at effort or work of breathing by thinking about how many words this patient's getting in a sentence, looking for accessory muscle use, and looking for a tripod positioning. We said that deterioration in even one of those areas usually means that you need to intervene. So let's talk about how to intervene in these cases. There are many different treatments for problems with oxygenation and ventilation, but there are some that are just universally applicable when you have a patient in obvious respiratory distress. So let's go over them. You can start with basic support maneuvers, which mostly refers to moving the patient to an upright position, using a jaw thrust to open their airway, or using suction to clear their airway. You can increase the amount of FiO2 that's in the environment using a device like a nasal cannula or a non-rebreather mask, or maybe a high-flow nasal cannula if you have that available. There are particular drugs that you can use that act immediately. So bronchodilators are great for wheezes. Vasodilators and diuretics are applicable if you have crackles. And if oxygenation alone isn't doing it, you need a machine that will blow oxygen into a person, like a CPAP machine or a BiPAP machine. Or you could just use a bag valve mask device to do that as well. If all else fails, you progress to invasive ventilation techniques, like intubation or placing a supraglottic airway. All the while, you need to keep in mind, could there be a pneumothorax that could be at play? And if you need sedation, ketamine is usually your go-to. So this is the respiratory treatment progression, and we're going to break down each piece of this. I won't talk about drugs today because we're going to do that in a separate talk. And I won't talk about invasive ventilation because we've got another module coming up on airway management. Ketamine has also been previously covered in a procedural sedation module. I'm going to mention it briefly here, but if you want to learn more about that, I would go back to that module for a deeper dive. Let's talk about those basic support maneuvers first. These pictures here show you a patient in an upright position and show you someone applying a jaw thrust. Easy things to do that are really important. An upright position is key because it does make it easier for the patient to spit or cough or clear their airway. And that tripod position recruits some of your accessory muscles. If your hands are forward and pushing down on something, you can use your pectoralis muscles and some of your neck muscles to help lift your chest wall. A lot easier than when you're lying down. The jaw thrust you know how to do. You learned how to do this in med school and in your anesthesia rotations. This basically just lifts the tongue out of the way so that you can alleviate any obstruction there. If you have a patient that needs help clearing the secretions in their airway, use a suction device. This is the most common suction device available. It's called a yonker, or at least I was taught to call it a yonker. I think other places in the world they call it a yankower, which is probably the correct pronunciation, but whatever. There are lots of different devices to use. You probably have this one available, but get to know what's available in the areas where you're going to work. So basic support maneuvers are easy and simple, and you should use them. Let's look at increasing FiO2. So we said that includes a nasal cannula, a non-rebreather mask, and high-flow nasal cannula. So a nasal cannula is something that you're probably already very familiar with. When you connect this to the wall oxygen, you usually turn it up to 1 or 6 liters per minute. And at the highest end, you could probably count on an FiO2 delivery of 35 to 40%. A non-rebreather mask performs a little bit better. When you're using one of these, you need at least 10 to 15 liters per minute. And you can probably count on an FiO2 somewhere between 50 and 75% when it's working really well. Now, some sources will tell you that you can get 90% or even better FiO2 from a non-rebreather bag, with the theory being that this bag fills with 100% oxygen. It's supposed to be a reservoir that the patient breathes from. And if you breathe from that and not from the environment, then you should be breathing 100% oxygen. There's a little valve in between the mask and the bag, which is supposed to close so that when you breathe out, your breath does not go back into the bag, which is why they call it a non-rebreather mask. You don't rebreathe back into the bag. There's also little valves on the side that are supposed to close to the outside world when you breathe in so that you're not breathing in room air, you're just breathing in from the bag. And if all of that worked perfectly, maybe it would be 100% or 90% FiO2. The truth is these masks don't fit that well. It's not a perfect seal around your face, and there's holes and stuff in them all over the place. So you always entrain a little bit of room air. You're probably counting on 50 to 75% in the best case scenario. The best case scenario usually means that you have filled the bag so that the bag has 100% oxygen in it, the bag's not collapsing, and that you've fitted the mask as best as you can to minimize leaks. There are some tricks that you can use to eke out a little bit more FiO2 out of these simple devices. So one easy thing you can do is just use both at the same time. So if you look at this picture, this guy obviously has a non-rebreather on with its reservoir bag. And if you look close, he also has a nasal cannula running underneath that non-rebreather. The theory here is that the nasal cannula can probably be counted on to give you at least 30% FiO2, and the non-rebreather can probably be counted on to get you at least 70% FiO2. So if you add those two together, maybe you're closer to 100%. I'm not really sure if the physics works that way, but the two together probably do give you more FiO2 than either one alone. Another option might be using flush rate oxygen. So oxygen in your hospital probably comes from the wall, and you probably have a little regulator like this. And those regulators, you can turn up past that 15 mark. So if you look real close, they range from 1 to 15, but there is a little bit of space above the 15. So when you turn the dial, the little ball can keep going up past it. And if you crank it up the whole way, you can sometimes get rates as high as 40 or 60 liters per minute. So it's quite a bit more flow. There are some problems that come along with this. So one is that it's really not very comfortable for patients. That much flow is really drying to the nasal mucosa. And sometimes the tubing will pop off just because the flow is so much that it pushes the connections actually apart. The best way to provide high flow oxygen is probably just to use a device built specifically for that purpose. So if you have access to a high flow nasal cannula, I would use that. This is probably the most comfortable way to provide high levels of FiO2 to a patient that needs it. This is different from a standard nasal cannula because the tube is much larger. So if you look in the picture, that's way bigger than a standard oxygen tube. And it's also fitted. So it comes in small, medium, large, and probably fits in the nostrils a little bit better. There's also a machine that warms the air and humidifies it, so it's much more comfortable and it doesn't really dry out the nasal mucosa. And the kinds of flows that you can get with this mimic that flush rate. So it's probably like 40 to 60 liters per minute for most devices. The FiO2 that delivers really is controlled by a dial. So you could turn it down to 21% and just make it room air, or you could crank it up all the way up to 100% or any number in between that you pick. The usual advice for dosing here is to max out the flow rate first and then go back and adjust the oxygen level. So put it to 40, put it to 50, put it to 60, see how the patient's doing, and then crank up or down the FiO2 as you need it. Now, in an emergency, you probably just use the max settings, like turn it to 60, turn it to 100%, and then just titrate down when things have settled down. You do have to be a little bit careful because higher flow rates can still be uncomfortable, just like a standard nasal cannula. So we don't want them on 60 if they don't really need it. But that high flow rate can also be useful because it sometimes gives you a little bit of CPAP. And I'll talk about what that means in a second. So that covers your options for increasing the FiO2 in the environment. And if you apply 100% FiO2 and things are still not settling down, you're going to have to find a way to actually blow air into the patient. So that moves us to our non-invasive ventilation techniques, which might include a CPAP or a BiPAP machine or use of a bag valve mask device. So usually when we talk about non-invasive ventilation, this is the kind of machine that we're talking about. A CPAP or BiPAP machine always includes this fancy Darth Vader mask with a good seal on your face. And there's always a machine next to it, which is essentially a ventilator or a device that blows air into you. So let's talk about how these machines work with some examples. So on a good day, your lungs functioning normally, they inflate and deflate just as you breathe in and breathe out. But if you're stuck in the hospital and lying on a bed for a long time, they might deflate a little bit more than usual. We call that atelectasis. They could also be full of gunk and fluid, and maybe that's pulmonary edema because you're in heart failure. A CPAP machine offers a treatment for both of these things. So CPAP stands for continuous positive airway pressure. And essentially what this is just a machine that blows a steady stream of air into you. That air pressure helps to open up parts of the lungs that have collapsed. So if there's some pulmonary edema there, that air pressure goes all the way down to the bottom and kind of squishes that fluid out of the way. If you have some atelectasis, that pressure exerts a little bit more pressure on your lungs and kind of re-expands areas that have deflated. The continuous air pressure helps keep open those alveoli, keep open those airways. And when you have more alveoli that are open and available, this improves your oxygenation. A BiPAP machine is very, very similar. So BiPAP stands for bilevel positive airway pressure. And this machine does exactly the same thing as CPAP with a constant steady stream of air that helps keep collapsed airways open, except that it also gives you a little extra pressure on inspiration. So the machine detects when you take a breath in, and it provides a little bit of extra pressure to help along that process. And the machine is smart enough that it can detect when you're breathing in and when you're breathing out and vary between two different pressures to help along both of those processes. The extra pressure makes it easier to inflate your lungs, makes it easier to take deep breaths, which helps decrease your work of breathing. And moving more air helps to improve your ventilation. So that's what we end up using a BiPAP machine for. Let's compare these two devices in a different way just to solidify this. So I've got CPAP on the left and BiPAP on the right. CPAP stands for continuous positive airway pressure, and BiPAP stands for bilevel positive airway pressure. A CPAP machine provides one continuous airway pressure, whereas a BiPAP machine alternates between two different airway pressures. There's an inspiratory pressure called IPAP and an expiratory pressure called EPAP. Now, for God knows whatever reason, EPAP is also called PEEP sometimes, depending on the machine that you're using. But there's no difference between those two words. They're exactly the same thing. They're both expiratory pressures. CPAP functions mainly to open collapsed airways, whereas BiPAP opens collapsed airways, but also has some extra pressure to reduce work of breathing. In this way, you can count on CPAP to improve oxygenation, and you can count on BiPAP to improve both oxygenation and ventilation. CPAP machines, for the most part, are used to treat sleep apnea, and that's probably the only time you're really going to see them in the hospital. BiPAP machines are usually what we use for respiratory distress, so that's the more common device you're going to encounter at work. So if I decide that I need BiPAP or CPAP, how do I order this? How do I use this? Most of us, to be honest, call an RT. And if there's an RT available, it's kind of their job to set it up and make it work. If you don't have an RT in your hospital, there's almost always a protocol, which is basically instructions for how to set up the machine. I won't go through all of this protocol here, but I will give you some of the highlights because these protocols usually have common features. Typically, they'll tell you to start with an IPAP of 10 or an EPAP of 5, and then they'll tell you that you need to reassess the patient every 1 or 2 hours. When you reassess that patient, think about your respiratory assessment triangle. Think about oxygenation, ventilation, and the patient's work of breathing. For CHF, usually the focus lands on EPAP, and if you need to adjust from 10 and 5, you'd usually increase things to 15 and 10. Whenever you increase the EPAP, you almost always have to increase the IPAP a little bit along with it. If there's no effect there, you'd usually bump up to 18 and 15. If we're looking at COPD or maybe asthma, the focus usually falls on IPAP. So if you got to go up from 10 or 5, you might increase to 15 and 8. And if that didn't work, you'd increase to 18 and 8. You increase the IPAP alone and not really affect the EPAP. Now, deterioration on a BiPAP usually means that this patient needs to be intubated. So if you're playing with these settings, you're increasing things and things are not going well, you should keep in your mind that that's probably where this is going. But we know that the best use of BiPAP and CPAP machines are individualized according to the patient's tidal volumes and to their tolerability. So before you go so far as to intubate somebody, if you have time, you might want to get some help and get somebody to adjust these settings for you or with you. A respiratory therapist is almost always your first stop. Not every hospital has them though. So you could talk to an anesthetist. They usually know a lot about ventilators and a lot about BiPAP and CPAP machines. Or you could talk to a critical care or an ICU physician and probably get some advice over the phone. There are some problems that can come up when you are using a BiPAP or a CPAP machine. Two main issues I want to cover. One is pneumothorax, and the second one is an altered level of consciousness. Both of these issues are actually highlighted on that respiratory treatment progression. So pneumothorax needs to always be in the back of your mind, and altered level of consciousness is sometimes something that we can fix with ketamine. So imagine that instead of having healthy lungs, you have a lung that has a pneumothorax. There's a tiny little bit of air that's trapped at the apex. Usually this happens because there's been a little hole in the lung and air has just escaped that way, but it can't really get out of your thoracic cavity, so it just kind of sits outside the lung. If I hook you up to a machine that forcefully blows air into your lungs, some of that air is probably going to find its way to your lung and out through that little hole. And if you're not careful, you might be filling that hole with air instead of the lung. So you could, with positive pressure, create a small pneumothorax that turns into a very big pneumothorax. And now we have a problem. So pneumothorax needs to be something that you keep in mind whenever you are using a CPAP or a BiPAP machine. You need to think about pneumothorax before starting that machine, and you need to think about pneumothorax if the patient suddenly deteriorates while using that machine. The next problem that we should talk about is patients with an altered level of consciousness and how to use BiPAP in a scenario where the patient's agitated or delirious. Unfortunately, agitation and delirium are really common, partly because respiratory distress and hypoxia do that to people, but also because these masks are just really not comfortable and some people are finding them very claustrophobic. If you have a patient that is agitated and you need to use a BiPAP machine, you might need to sedate them to get it done. I think you can see our procedural sedation module for more information, but ketamine is probably the drug of choice in these cases. And typically we'll just use small doses like 10 or 20 milligrams every 3 to 5 minutes just to try and chill things out a little bit. It's usually considered the drug of choice because it really doesn't impact your airway reflexes. So people will still be awake enough to cough and clear their throat if they really need to. And that's an important point because there is nothing about a BiPAP or a CPAP machine that protects your airway. In fact, just imagine what would happen if this lady were to vomit, right? If she barfs, it's going to go right into that mask, and that mask is connected to a machine that blows air into you. So the barf comes out, and then it goes blown right back into your lungs and your airway. So she needs to be alert enough to take the mask off, to sit up, to cough, to do the things to protect herself. If you have a patient that is unconscious or clearly not protecting their airway, BiPAP, CPAP, not the machines for you. Those are patients that need to be intubated. Setting up for intubation takes some time. So if you have an unconscious patient, you may need to find a way to temporize things until everything is ready. And that usually means using one of these devices, which is a bag valve mask device. This is typically for the unconscious or the apneic patient, and it is so named because it has many different bags and many different valves on it. This is what the full device looks like. You've probably seen these before. They have a reservoir bag on the end, just like a non-rebreather mask, which needs to be filled with oxygen. And there's a little valve in the middle here that prevents air from going back into that bag. This is a self-inflating bag that when you squeeze down, pushes air forward, and when it reinflates, it sucks air from that reservoir. So oxygen flows from the reservoir bag into the self-inflating bag, and then goes through the mask into the patient. Now, just before you go through the mask, there is one more valve stuck on the end, which prevents the patient's exhalation from going back into the self-inflating bag. So one more one-way valve all the way through. That last valve is sometimes replaced with a PEEP valve. So you might see a BVM that's got one of these little red things on the end. If you look really close, you can see numbers like 10, 15, 20, and that refers to the expiratory pressure that you can dial in on one of these things. Basically, all this does is it changes the size of the hole that the air is coming out when the patient exhales. So a really small hole gives you high pressure, and a really big hole gives you low pressure. So you can change the amount of expiratory pressure, which kind of makes your BVM into like a little mini BiPAP machine, right? How hard you squeeze that self-inflating bag determines the inspiratory pressure, and then what you set this little red thing to determines the expiratory pressure. A BVM, like any device, needs to be connected to some source of oxygen. So usually we connect it to tubing and crank it up to 15 liters per minute. And with good technique, you should in theory be able to get 100% FiO2. Most of this depends on getting a really good seal with the mask and opening that patient's airway. So when you do this, you need to do a really good C and E technique like you learned on your anesthesia rotations. If you have trouble with that EC technique because you've got small hands, the best move is just to get a friend. So you can hold the mask on and open the airway with 2 hands, and then you can have a friend that squeezes the bag for you. This is difficult to do for a long period of time, even if you're using that 2-handed technique. So if you find yourself doing a bag valve mask ventilation, you probably should be thinking about intubation as your next step. And that is the complete respiratory treatment progression. Treatments that you can use for any patient that is struggling with their breathing and respiratory distress. Start with basic support maneuvers. So sit the patient upright, use a jaw thrust to open the airway, and use suction if there's stuff in their mouth. Increase the FiO2 with a nasal cannula, a non-rebreather mask, or a high-flow nasal cannula. Use drugs appropriately like bronchodilators for wheezes, vasodilators and diuretics for crackles. And if you need to blow air into somebody, think about a CPAP device or a BiPAP device, or just a bag valve mask device. And if you need to, you'll progress all the way to intubation or placing a supraglottic airway. Keep pneumothorax in the back of your mind, particularly for those patients on CPAP or BiPAP that you're about to start, or patients that deteriorate after you've started. And keep ketamine in your mind as well for patients that have agitation but really need a BiPAP or CPAP machine applied. That's it for now. We'll talk about drugs in a later talk, and we'll let you know when that one gets posted. And hopefully we'll have an airway module organized for you very soon. I'll see you then.